Hello, my name is Dr. Kevin Curran. I am a pediatric bone marrow transplant physician. I am the pediatric director at the Sloan Therapeutic Center at Memorial Sloan Kettering. In that role, my job is to develop translational research with the use of a new technology called CAR T cells. CAR T cells are a form of immunotherapy. Immunotherapy is where you use your immune system to fight cancer. The Max Cure Foundation has really provided vital funds to help us translate. Right now in 2018, there's a vital need for funding to help kickstart translational research. We can find funding for the trials, what we can't find is funding to start the trials. And that's the development of the IND, development of the GMP grade DNA that we're going to use to transform the cells. And thanks to the Max Cure Foundation, we were able to do that. And so with your help from the donors that have helped support the Max Cure Foundation, we've been able to do that.
Well, thank you. I think you said everything that I really was hoping that you would say in terms of what we're supporting in terms of your research and what role it plays. And it's really important on our end to follow up and get updates to see how things are going. And so the research that we are helping to support, the goal is to create clinical trials.
Yes.
Right.
So right now, when patients come to our clinic, especially when they come to a large center like Sloan Kettering, they're coming because the standard treatment failed. And the hardest thing we do as doctors and researchers are when patients come to us and we don't have new options for them. And so what our goal, what our real charge what drives us to come to work every day is find new cures that work better, and cures that work are more effective and less toxic. And so the research that the Max Cure Foundation supports is something called CAR T cells, and we're going to use that for patients with relapsed AML, a type of leukemia that has failed to respond to standard therapy. And unfortunately, for those children and adults who have relapsed AML, there are no easy cures. And the cures we have are very ineffective. And so our goal is to make those better. And with the support of the Max Cure Foundation, we're able to do that.
There's two things that I want to ask you about based upon, knowing what you want to do and knowing what you're working on. First is when you say CAR T cell therapy, it's the sexy hot button, funding bucket for a lot of organizations that are trying to support these types of therapies. What can you tell us about what CAR T cell therapy is?
So your immune system has lots of different cells that are in your blood, and unfortunately, cancer has a way of avoiding those cells. Those cells should actually be able to recognize and eradicate cancer cells, whether they're in your liver, your brain, your pancreas, or your blood. For patients with cancer, that process is failing. And so what CAR T cells are is a way where we actually pull out your immune systems, we use viruses to modify them, and we essentially teach them how to see cancer. So the immune systems are blind, we give it back sight, and then we bring you back in the hospital, infuse the cells back in, they find the cancer and get rid of the cancer.
Got it. They've really shown a tremendous amount of promise.
So for other types of blood cancers, other types of leukemia and lymphoma, these have been groundbreaking. So not only in children, but adults with lymphoma, children with leukemias, they have resulting in response rates greater than 80–90% of those patients. And those are the hardest to treat patients. Those are the patients that have come after they failed multiple lines of treatment. And so our goal as researchers are to say, okay, this cure is working now. How do we make it work for other cancers? And thanks to the Max Cure Foundation, we're able to actually start up the trial. And what you actually funded was step one is to make the DNA. So you have to make the DNA and it has to pass a rigorous number of tests. So we actually had to send that DNA to a company that specializes in making DNA up to the standards that the FDA allows. And that's called GMP grades, so good manufacturing practice. But essentially what we get back is clean DNA that is allowed to now be used for these trials.
I mean, look, I'm excited to see where everything goes in terms of, the outcome of the trial. where are you right now in terms of how far out are you from enrolling patients, and where are things going in the next 6 to 12 months?
So we hope to open the trial at the end of 2019. A number of steps are going to have to happen. We sent the DNA to this company in, I want to say, September. We got the email a few weeks ago that it's in production and they should have it to us at the beginning of 2019. The next step is we're going to need to get funding to enable us to make this master cell bank. And this master cell bank is something that we make here at Sloan Kettering, but it's very costly. And when we have funding for that, we can make that. We hope to have that process done by June of 2019. And then we'll go to the FDA and say, we're ready to start the trial. Will you allow us to enroll patients? So Q4 2019 is our projected start date.
Got it. When you say that it's a lot of money, what are we talking about in terms of the cost and what you need?
It's about $200,000 to make a master cell bank. And that's after getting the DNA back in. And then we bring it to our researchers. So we're lucky at Sloan Kettering. We have institutionally, we've taken this process, and Sloan Kettering really has taken a leading front on this throughout the whole world, where we say we want to create new forms of this CAR therapy. We want to target ovarian cancer, lung cancer, brain cancer. I'm leading the program for AML. And so there's a number of us researchers that get together and we have to work out and say, what's our priorities? And thanks to funding organizations like the Max Cure Foundation, I can say AML is a priority. So now we want to move forward and say, okay, let's fund that master cell bank and let's get that open so that we can start treating children in 2019.
Do you have any funding prospects ahead for the master cell bank?
We're still working on it. We hope to keep finding it. There's a number of grants that we'll be applying for.
Okay. Well, you know, for us, it's important to find projects like yours that, you know, we use the word impactful, and that's really this amorphous concept as to what impactful means. But, you know, when you talk about numbers of response rates in the most difficult cases of 80, 90%, and then, you know, when you're talking about AML, which, correct me if I'm wrong, accounts for the largest number of deaths of any specific type of cancer at the pediatric and AYA level, you know, I think we can all be excited about this.
So yes, AML, especially relapsed AML, the survival from that is very low. You have to combine both the adults and children to get to that number one, you know, largest number of deaths for leukemia is where that would go. Leukemia and the blood cancers, in a way, we're very lucky because they grow so fast, we can treat a number of patients with it. If you walk in the door, it's about 50 to 60% of the patients we can cure, but that other 40%, those are the ones that we're really targeting. And when we say we cure the 50 to 60%, that's curing them after years of treatment and possibly a bone marrow transplant. So our treatments are kind of two-step. One, let's get the ones that are failing completely now. Number two, let's make them work so that we can actually offer them to everyone. So when you walk in the door, we look at your cancer and say, you know what? CAR T-cells immunotherapy is the way to go. And so that's what our real goal here with these trials is.
What about using it as a frontline therapy? Is that?
It's ultimately, that's where we want to be. So we're going to move now. So we have this therapy for acute lymphoblastic leukemia and non-Hodgkin lymphoma. Those are B-cell cancers. And the goal now over the next 5 years is say, okay, it works in the relapse setting. Let's make it work in the upfront setting, because children are going through years of toxic therapy. You can look at the data. Patients who have received years of therapy, overall, the problems they have, secondary malignancies, poor performance in school, poor performance cognitively. We really want to be able to turn that back and say, you don't need 3 years of chemo. You need 3 months of treatment and a lifelong cure.
Well, I want to say thank you from all of us on behalf of the Max Cure Foundation for what you're doing in terms of your research. You know, when we were first introduced and we first spoke, I knew it was a project and a focus that we wanted to get behind, and I want to make sure that we can get behind even more and try and help accelerate the funding so that we can get it into the clinic as soon as possible, understanding the hurdles that lay ahead of you. But with that said, we're thrilled to support your research and hope to be able to continue to provide more support as the years go on. That's only possible through donors, and the research that we helped fund was also made possible for us through the Connor Fund at the Max Cure Foundation, which was created in partnership with Beth and Henry White from Connor Cures, who lost their son to ATRT. And we can't do it without our supporters, and I would love to make sure that we can get our supporters to help you out and move it forward as fast as possible.
Well, thank you. On behalf of MSK and our entire team, the entire CTC group that's moving this forward, we thank the entire organization supporting it, and we look forward to 2019 where we're going to get this moving forward and into patients.
Fantastic. Thank you for your time, and we look forward to more updates.
Look forward to it. Thank you.
Cool. Thank you. Okay. We can cut from there. Cool. Awesome.
We'll get the DNA back. We'll get the DNA back. We should get it back. Okay. Truthfully, when we sent it down there, they couldn't get it to work.
Wow.
I literally probably had, we used to do it in-house. We used to make it ourselves, but then cost effective, and they had to reserve an entire room for it. And so it became, so when I did the other trials, we used to make it ourselves. So we had to outsource it. And so this company has outsourced. We've probably done 4 or 5 with them, and this is the first time they had trouble with one.
Yeah.
And so that was unfortunate because that probably cost us 3 months. And so we got it, and they had a project. I want to say it was the 12th of December. It was going into production. So I haven't got it back yet. We do have a backup plan. There is another way where we can go to a different company and say, you know what? Don't grow it. Just give us the sequence.
Yeah.
So we haven't gone down that route because that would be, like, again, more time waste. But we're still looking at it, and I really do hope that we get that master cell bank. If we get it by Q2, the end of Q2 of 2019, we're in good shape.
Okay, good. And in terms of the funding that you're talking about, where do you stand in terms of grants and?
So we have partial funding from the department where they will partially fund the bank, but not the whole thing.
So are you still? Is it still around 200?
It's about 200, yeah.
Okay.
And that gets us the master cell bank, and it gets us. There's a core that helps us write the IND. And so because talking to the FDA is a big deal for an institution. It's If I can't as an investor, the old days, the 80s, I would just call up the FDA. But then the problem is I'm calling on behalf of Sloan Kettering, and that's a mistake. And so we were smart where I actually used to be on this committee. And there's a committee of doctors who actually review and vet the proposals and then send it down. And that committee has almost like if you think of like a Senate committee, like a committee of people who actually craft it for us. So there's a core that helps me write the IND, which is a pretty complex process. We're pretty good at doing it now. And so I have to pay their fees as well.
Got it.
So,
okay.
It's a good thing, actually, though, because the worst thing we could do as an institution is send down to the FDA incomplete documents, and then they're going to say, you know what? You guys aren't ready to do this.
Yeah. And then you get a further delay.
Yep.
Got it.
And so that kind of encompasses those 2 costs.
Okay. Okay.
Right. But we'll talk more as I move forward. Don't worry. I'll email you when I'm looking for more funds.
Well, let me see what we can potentially do here.
All right.
So excellent.
Have a great holiday season. Happy New Year.
You too. Thank you. Thanks, Elliot.
Bye. Thank you.
Bye. Thanks, guys.